the idea of this fireside chat, I thought, would be a couple of things. One would be to entertain questions from the audience, and I've already had people ask me questions, so please feel free to ask. But then it is to discuss what roles we play and how we do this in terms of the journey of a patient with Parkinson's disease. And what I was saying to Heather just a couple of days ago was that, the way the, quote, journey transpires is that often at the start of the diagnosis, it's the doctor, nurse, then it becomes doctor, nurse, and it becomes doctor, nurse. That's the journey of how we see in terms of Parkinson's disease. And we have an approach that we take that allows me to understand the disease from multiple perspectives, which is what Heather brings to the table, that the white coat, black art, that science that we bring does not always have enough depth to be able to understand. So what we thought we would do just ad hoc is to talk about the journey that way. The new patient, the patient that has, and the caregiver, and the patient that is, say, few years into the illness, and then the later patient. In fact, Heather's main role, in addition to the other main roles, is also to be in charge of those device-aided therapies that we talked about briefly in my talk. So maybe what, Heather, you can do is ask me the first question.
Well, first of all, I'm disappointed you don't listen to T. Swift. Shake It Off is a really good song. But no, so basically I hear frustration. The whole journey can be a long process. We ourselves in London have an 18-month wait list. Is that better?
I can barely hear you.
Hello? Don't move. So basically, we do have an 18-month wait list, which I know can be very frustrating when you want to come see a movement disorder specialist. The one thing I can advise is once you receive an appointment, try and get on the cancellation list. A lot of people get in quicker. So if you know people who have it and want to see a specialist, do that. The journey at the beginning, so I guess, like you said, you're predominantly, when they get a new diagnosis of Parkinson's, I think the issue for most of the patients and caregivers is, what do I do with this now? And a lot of times we give you that diagnosis and then there's not a lot of follow-up with that. So I try to be available to patients if they have questions, because generally speaking, the first 5-7 years, there's not a lot of issues. So I don't hear from a lot of the newer patients other than if they're nauseated from levodopa or those sort of issues. So I guess part of my question too, I know some people ask, will I be started on levodopa? Will I be started on Mirapex? What's your preference?
Yeah, so that's an excellent question. When I see a new patient, I divide the discussion into a couple of parts. The first is discussing what it is that Parkinson's disease pathologically or pathogenesis, why does it happen? Because a common question that we see is, why me? And then based on that discussion, whether it's genetics or environment or those kinds of things that are still very nebulous, we discuss that why me question first. The second part is the quality of life issue that I mentioned before, or discussed. And we really want to explore what it is that the patient or their caregiver are disabled about. So if a younger patient that is not that disabled with their disease in terms of function and quality of life, but still needs some degree of medical intervention, then that intervention would potentially be with this drug, pramipexole, that you mentioned, which is a dopamine agonist. And I discussed this concept of dopamine agonist and levodopa and what it is, and I'll do that now. So our brain cells manufacture dopamine. They manufacture all kinds of such. In fact, funnily enough, there are only 7 neurotransmitters in the entire brain, only 7, right? And with those 7 neurotransmitters, 5 of them belong to a class called catecholamines. Amine, right, having a nitrogen moiety on it. So they're all very similar. Serotonin, dopamine, epinephrine, norepinephrine, et cetera. They're very similar in their structure, and they're manufactured in the brain. So when we give levodopa, as I was mentioning, I give the precursor, and then the brain cells that are still functioning very well make that into dopamine. So that's the real stuff. That is the quality dopamine that is manufactured by the brain. But it has all those issues in terms of absorption. It has the issues of a very short half-life, which means it lasts for a short period of time. You have to take it 4 times a day to start. You can't take it once a day, 4 times a day, because it wears off. So in those patients where those kinds of issues are going to cause trouble, about 20 years ago, more than about 30 years ago, in the early 70s actually, a drug called bromocriptine, which is artificially made dopamine. So it's not actually dopamine, but artificially made. What does it mean? It means it binds to the same receptors, dopamine receptors, on the neuron that is on the other side of the one that's releasing dopamine. So post-synaptic neuron, pre-synaptic neuron. This releases, this binds. That neuron has dopamine receptors, which dopamine binds to. So companies made an artificial dopamine called dopamine agonist that would bind, that would avoid this conversion, avoid the absorption issues. And so those, unfortunately, like anything else, if you get the real thing, it was funny because years ago when I'd gone to Alaska hiking, the coat that I could buy that was made locally was $1,100. The one made in China was $99, right? So it looked the same to me, except that this was genuine and this wasn't. And so its quality, its ability to keep me warm would be radically different, and handmade versus not. That's the kind of thing that happens with dopamine agonists. Their potency is less, hence their ability to produce symptomatic benefit is lower. But here's a case where somebody needs something. If I was freezing to death, I'm not about to spend $1,200 on a coat. I'll buy the cheaper one and keep myself warm at least the way I need it. That's how dopamine agonists are generally used as initial therapy. And when we talk about later on, we'll get into that in adjunct therapy. So I choose that based on the amount of disability and the ease of use of the product. Because there's also a dopamine agonist patch, rotigotine, which is a 24-hour patch. Put it on, take it off the next morning, put the next one on, put the next morning. So the numbers, however, I would say about 10% are pure dopamine agonists at the start and 90% are levodopa. Why? Because the biggest bang for buck still comes from levodopa.
Okay. Yeah. The other frustrations, and I know we both see it in clinic, is when they come from the community and they've been mismanaged a lot with medication. We have people come in, they're on 6 times a day Stalevo.
Yes.
Early on in disease. So just talk about your frustration that way, I guess.
Well, that's a very important point in terms of how, so we see early disease, 2 types of patients, not the phenotype that I talked about, but the first would be for a diagnosis. So somebody that has tremor, is it essential tremor? Is it Parkinson disease? So for diagnostic reasons. And then that's the group that we first concentrate on this is Parkinson's. And the second group are those that require therapy, which I just talked about. But the third group is actually a group of patients that somebody has made a diagnosis and has initiated therapy. Now, there are 2 main problems there. First of all, if therapy is not initiated correctly, then somebody could have been given levodopa half a tablet twice a day, and it doesn't work. Well, because it's wrong, or half a tablet, it happens all the time. And then that person says, oh yeah, I tried levodopa, it didn't work. Well, I mean, you're talking about the best, ball player on the team and saying, well, that person's not going to play. And this is awful because it reduces patients' quality of life. And we've had patients that have basically waited 5-7 years on no therapy in terrible shape because it was not used properly. The minimum starting dose of levodopa would be 1-4 times a day. And the reason is because how much actually gets into the brain. The second is also true. Very high doses. Somebody was asking me back there when we were having lunch that very high doses of levodopa to start with. So if I actually see someone on that kind of like 6 times a day, 2 tablets, early in their disease course, that's also mismanagement. There's a middle road. Now, certainly we do tailor, as I said, every patient differently. The third is what I think you're talking about in terms of what you see on the phone call from pharmacists. So what are the kinds of things that you see?
So Yeah, many questions about amantadine, levodopa as well, like how often they should be giving it. They'll go ahead and do changes, especially if a patient's hospitalized. That's another frustration I have. They're not getting the medication on time, and just feel that they can stop the medications at times, and those are all really frustrating circumstances.
Well, one of the things you were mentioning, which is actually important, is that pharmacists will put on the bottle, and which is good, and I'll get into that just a little bit, take with food, which is exactly the wrong thing to do, right? Because patients with levodopa cannot eat for an hour, right? Because proteins that are present in our meal, what you had, I think the regular meal was chicken, right? You can't take your levodopa with that. You have to have taken it an hour before, right? Because anything that has proteins in it will interfere with the absorption. Even a glass of milk. Regularly, people will take a glass of milk with their levodopa. This is wrong. The reason, you talked about nausea briefly, the reason that we ask people to take a little bit of food but not meals is because sometimes this drug will cause nausea. And there are two types of nausea that Parkinson patients get. The first one is nausea that you get as soon as you take the tablet. Now, within minutes, okay? Now, this drug hasn't even gone past the stomach yet, let alone into that jejunum that I was talking about. So this is not nausea that has occurred because of the medicine having reached your bloodstream. This is nausea that occurs because there is irritability in the stomach that goes up the vagal nerve, and generates a nausea reaction. Right? I'll give you my personal example. Rarely do I take any medications, but vitamin D. I tried once to say, okay, well, let's see what this is. And for whatever reason, immediately, within 5 minutes, nausea, terrible, stopped it. Right? And the reason for that is because our nausea reaction has to occur immediately. Let's say you swallowed something you didn't want to swallow. You don't want to wait for an hour before you puke it, right? That's terrible, right? Right? So that's why you want that Ipecac now in the emergency department. You want to get it out now. So we have a reflexive vagal reflex to be able to vomit, and that's safety. That's why children throw up all the time. They eat, out it comes on your shoulder. Not a good thing for the parent, but works for the child. Not till it's all absorbed. So that's the first kind of nausea. It's kind of like thirst. You have a glass of water, you feel really thirsty, you drink it, it feels good. But your biochemistry hasn't changed yet. Your pH in the blood is still about the same. It'll take 40 minutes before all that water is actually absorbed. So our systems are designed to give that immediate signal. That's the first kind of nausea. That kind of nausea is the one that is helped with a little bit of food, because it allows that whatever coating or something, some mechanic. So taking that with. The second kind of nausea occurs when you have that levodopa enter the bloodstream, and it gets converted to dopamine outside the brain. 90% actually has that happen. Well, whatever goes in your bowel is also then converted. But your muscles do it, your liver does it. Now that dopamine goes up into the brain and to the brain stem, where it generates nausea up here. That kind of nausea is not treated with food because it's already entered your bloodstream. See what I mean? The two different things. So when you get nauseated immediately after taking levodopa, that's when that little bit of food would help, not protein. Because what protein will do, yes, it'll help with your nausea. That's because the drug didn't get into your brain. So that's not a good thing. That means you're not getting therapy. So that's one of the problems that we face all the time, that patients are told, take with food. And the funny thing is, even after instructing, Heather will receive that call, where we've told everybody every time, that I've done for 27 years, and still people come back taking it with food, with proteins.
And another important thing that I think is, I just wanted to state while everyone's here, is when you're hospitalized, the medications that shouldn't be given are the Demerol, Haldol, and Maxaran. And a lot of people don't know that, and so if anyone's going for hip surgery, knee surgery, again, across the board, we're trying to get it in the hospitals where it kind of flags when a Parkinson's patient gets in there, so don't give those medications, but that's not enforced yet, so it's important to be aware of those things.
In the early journey, do you get patients calling you after we've seen them? Because one of the things I've always wondered is, we all wonder about this, is what happens to a patient once we give this diagnosis of Parkinson's disease? They walk out of our clinic, We go on to see the next person, and you walk away from our clinic, go into the parking lot, and you're driving to Kitchener, let's say, or Hamilton, or somewhere, Owen Sound, and you're thinking about what you've just been told. Many a patient already knows. Do you get calls from people to talk to you after initial diagnosis?
I don't get it a lot, and I think that's something lacking in the system,
Yeah.
especially if you don't have the whole interdisciplinary team of social work and everything. That's kind of me. So I do the nursing, but I'm also kind of the social worker, and I'm not trained in social work, but I don't get a lot of it, and I think that's where a fair number of people fall in the cracks, and they're left alone, and that's something that I wish would change.
Yeah, I think that's a very important point that I wanted to bring up, is that as a resource person, it's best that you call us to answer those questions that might come to mind. And they could be anything. They could be from the point of view of progression, and all of those things cannot be answered. And even if we've tried to answer many questions in the clinic, I wonder many times, and in fact, I know this already. Once we tell someone that they have this diagnosis, whatever we say afterwards, a lot of that information is probably not registered. And it's forgotten, not because of the fact that they haven't captured the information, because you can imagine the attention after that saying, I've got Parkinson's disease. And then beyond that, now I'm going to talk about all these other pharmacological things, not there. So that call back actually of the early patient would be very important to call back, and because that's the resource that Heather, certainly after all these years of managing every stage of Parkinson's, would be very good at. Right.
And that's something that I think is important. Is couples, it's overwhelming too, because your whole dynamic, your whole relationship is changing. And I think a lot of times what I try to focus on more and more these days is the caregiver. I really worry about my caregivers. And I guess we'll talk about that a little more when we're talking about advanced things.
Yes.
I guess we'll now transition kind of this 7-year plus when they start to have more motor fluctuations, dyskinesia. So then I get probably a fair number of phone calls. People are saying, Heather, my medication's just not lasting. Like, what can I do here? We have to decide whether we up the actual dosage or we put the dosages closer together. If there's dyskinesia, do we need to incorporate amantadine to try and help with that? So we do get a lot of those phone calls as well, and even our patients that come back in that time frame, we have to deal with those issues. Therein can come the discussion of advanced therapies or device-aided therapies if it's something that someone's willing to go through. And then, as Dr. Jog mentioned earlier, we do the off-on assessment on everybody to make sure that there's a DOPA response before we offer those, and of course the neuropsychology that way as well.
I wanted to ask you a question about resources available. We had somebody come up to our table and say that they've started a yoga class, or I heard from Shelley just now that there are 7 Rocksteady boxing things available. We are unaware of what are your thoughts on this?
Nurses across the board, we've been even Toronto Western, like even for the later stages for palliative care, for things, we're not aware what's out there. So I don't know if there's, yes, I can refer them to Parkinson's Society. I can also, Parkinson's Foundation has like individual, whether it's non-motor or motor symptoms, you can print off sheets. There's a wear and care kit, so if you're gonna be hospitalized, you can fill things out. But there's a lot of lack for resources, and I don't even know what's all available, even in this immediate area, to be quite honest. And at the nurses meeting I just had at UH this past week, I did say to them, like, we need education. We don't have outpatient nurse educators to give us and find these things, so it's up to me to kind of figure it out, but it's not always easy to find.
Well, one of the problems that I've been doing this a long time, about 25 years ago, we tried to, at least in the bigger towns like Leamington, Godbridge, Sarnia, Kitchener, Cambridge, to get an idea of who would be interested. This is Carolyn Connors' time. Physio, OT, social worker, speech therapy. There wasn't boxing and these kinds of things at that time, but the regular pharmacy, who would be locally an expert? And I had a model of this. I used to go to Thunder Bay. For 17 years, I went to Thunder Bay every 3 months, and we had a movement disorder clinic. I had a movement disorder clinic there for many years. And initially, it was in the private clinic, and then finally, long story short, managed to get into St. Joseph's Hospital there, where they had a day program. For the first 2, 3 years, we had a day program where right across the clinic was a regular day program, but the physio OT people could, because it was Thunder-based, local, could be referred. And then unfortunately, hospital resources, they took that away. And I noticed that. And what ended up happening was that it was so good that anytime we had somebody from Thunder Bay call, they'd say, oh yes, John Smith, a pharmacist, Mr. So-and-so, is the pharmacist that you go to get educated about things such as protein interaction. Why does this drug cause this? But the problem with that was, in that case, the hospital dismantled it. And so I tried to copy paste that here to get an idea in local regions. If somebody needs speech therapy in Owen Sound, who's the speech therapist for Parkinson's that I could refer to? Or physio in Leamington, who would be the physio that's not doing chest therapy for pneumonia, but also is interested in that? The problem I faced is that initially we did all the work, got the teams, and then the person moved away, family issues happened, pregnancy, loss of something or the other, and then that person changed. And we didn't know that this had happened. And so it's very difficult for us to know, do you think that it would be helpful to have, let's say, PSSO be in charge of something like that to keep us up to date?
For sure. I would love to have some sort of central resource place for the patient. Like I said, even palliative, even discussions about MAID, anything like that. Just a direction to go for our patients.
Yeah. And the main problem with us is that, it's essentially in our team, it's Heather, I, and then my fellows. And Shelley knows this very well, that, all of our fellows that many of you that have come to clinic will see, most of them, actually about 30% happen to be Canadian, but almost all of the other fellows are international. So Melanie just graduated, she's from Lima, Peru. Gala is from Mexico City. Yasmin is from Dubai. Mohammed that's coming is from Saudi Arabia. Ela is from New Delhi. I mean, these people are all from outside, which is a great thing for us because that's because of our international reputation. People come from all over the world to train, but then they leave, right? And so, and many a movement disorder person that I've trained has gone into basically private practice. So Dan Mendonca is my fellow. Mary Jenkins was my fellow. Yahya Muhammad in Oakville, Chai, John Adams. All of these people are our fellows, but they are not doing, they're solo practices. So 2 fellows that we've hired recently, Dr. Das and Dr. Murgai, are solo practice, single people, right? So, which means no fellows. And the volume of patients is so high that we don't have the time to keep up with the resources that are outside. And I think we tried before to get someone from PSSO to come to clinic to try and immediately connect them. We're trying to do the genetics. We're trying to understand how to treat them. And on top of treat the individual, on top of that, not having these resources is a big limitation, which means that we don't provide that care even if it were available. I think that's you agree that that's a big gap?
Yes, huge gap.
Yeah.
Huge gap.
When the patient that we see in that middle stage of year 5 to 8, 4 to 8, where they're developing these things such as fluctuation and dyskinesia, what is the kind of things that you tell them on the phone outside of medical management? Do you actually, how do you assess them on the phone?
Yeah, it's difficult on the phone, obviously, because I can't do the UPDRS and actually see them with my eyes. But I basically just get them to describe what they're feeling, describe, how long before your next dose are you wearing off? Is it every dose that you're wearing off? Is the dyskinesia intrusive and bothersome to you, or is it just bothersome to your spouse who's looking at it? Because it may not be bothersome to the patient. So it's getting down deeper and trying to get it. It gets hard sometimes though too, because some patients frankly don't know the difference between a tremor and dyskinesia.
Exactly.
And so what they're describing may not be actually what it is. And so that's why it's so important for people to come to the clinic to be seen in person.
Yes, and that's one of the things we've found, that unlike epilepsy management or patients who have TIA with stroke, where you can do this online, right, during this COVID. We cannot do that in patients with Parkinson's disease, because we need to understand, as Heather said very correctly, whether they understand that off is actually not a state in which you normally would consider. So somebody that's nice and quiet and looking at television is quiet. That's not on, that's off, right? That person's unable to get out of the chair, hence the reason they're sitting very quietly, right? Whereas dyskinesia, this movement, which might sound like it looks bad because you look dyskinetic, is actually on. So to us, an on state may be very different. And this is not simply an academic problem. This is a problem that we've faced since the beginning of the therapy of Parkinson's, to get patients to understand what is actually off and what is not off, what is on. Sometimes these could be just non-motor symptoms, anxiety, so developing that feeling of what am I going to do next? I need to take my medicine. It's another hour still. This could be a wearing off phenomena. And this history is very, very important for us to be able to make that therapeutic change. Because because the patient and the caregiver are the eyes and ears for us to understand that. That is why many a times, even Shelley has said to me or other, that do you have to come to the clinic? I mean, it's difficult for them to come. You have to come to clinic. Because unless we can actually lay our eyes and hands on the person and understand that, well, that's not that. And we have seen that. Referrals that have come to us, as I was saying before, and you look at the amount of somebody's on this, and how did you get here? Well, the doctor told me to do so. Well, that's the bad answer. And the reason that that's a bad answer is because there's been a miscommunication. And then what we do many times is, okay, somebody's on 2 tablets 6 times a day of levocarb. At this stage, you shouldn't be on this. I'm going to make you sit outside for 4 hours. Your next dose is due when? At 1 o'clock? Well, it's already 3, and you're still on. That's on. You don't need to take the extra. And so this is the kind of thing that outside is impossible to do. And we've seen this in the last 3 years far more, where patients are on schedules that are not comprehensible as to why you got there. Now, when we have patients on schedules like that, 2, 2, 1.5, 2, 1, 1, Heather will know at the other end that I've done that for a specific reason. So yesterday we saw somebody that is on 1.5 tablets every 2.5 hours. And it was very clear on history that really the morning was not good, but by the time the afternoon and evening came about, the person was so dyskinetic that they were not able to function. So here's somebody that is off in the morning and then heavily dyskinetic and excessively on in the afternoon, yet the same dose all the way through, right? So either the physician or the patient didn't. So we shifted that. So this person is going to take 2, 2, 2, 2, 1, 1, right? Because we want to load in the morning. Now let's say that person came to me that way. What do I expect? Or Heather expects that that patient knows why they got there. Right? They have to know and say, yeah, Dr. Smith was treating me, and what was happening was in the morning, it took me 4 hours to get on, and I got so disconnected in the evening. And I was, okay, that makes sense. See? So that's really critical. That's what that tailored approach is. And so what do you do when something, is that something that you do regularly on the phone with these people, readjust and move?
I do.
Yeah.
I have taken the autonomy just to kind of do that and not just bother you, unless it's really complex, and then I get the fellows to do the little follow-up call and do the tweaking for me. And then the other stuff that's very difficult for us is that a lot of the non-motor, like we really need to be urologists, mood disorder specialists, sleep specialists. It gets very complex and complicated. Sleep's a huge issue for our patient population. There's a few we send off to the sleep clinics, but otherwise, it's tricky. The RBD, as someone mentioned earlier, you're getting punched in the face, so many of our couples sleep separately. So there's, again, a whole dynamic behind this disease. And
the important point that she raised is that, that's why I showed you that first slide, all of that is actually still Parkinson's disease. And yes, we have to become urologists and psychiatrists and gastroenterologists, et cetera. There's a different discussion about the scope of practice, but you would never be able to get into a gastroenterologist to treat your constipation for Parkinson. They would never take you. We have to. On the other hand, it's important that the patient and caregiver realize that it is in the domain of Parkinson's management for us to be able to help your anxiety, with your mood disorder, your hallucinations, and all those things have treatable options. So REM behavior disorder, sleep dysfunction, we have treatment options available to be able to treat those things, and we do those. So important for you to be able to understand that that could be part of Parkinson's disease. No, I don't treat gallstones, but at the same time, these other conditions are part of Parkinson's disease management. So, in our questionnaire, we always ask in the review system, cognition, mood, hallucinations, anger, lightheadedness and orthostasis, et cetera, et cetera. There's a question back there?
I know my GP refuses to treat me for any Parkinson's-related symptoms.
Say that again, sorry?
My GP refuses to treat me for any Parkinson's-related symptoms. She says it's up to you. If I want anxiety pills, no. If I want this, no. You got to talk, as you said, problems with bowel or whatever. So it's very frustrating because I can't get hold of you, or I don't feel that I should be calling you. Heather, I think you're going to get inundated with questions after this talk. I don't know if it's a good idea for you. You're going to be so busy. But yeah, what do you do? Like when you report back to my doctor, do you not say, well, you should be prepared to treat her for this, that, or the other? Is that a way of sort of shortening the process or things like that,
That's a great question. Let me throw it out to Heather. What do you think your role compared to what the family doctor, what is your experience with what she's very nicely saying?
I do have frustration with family doctors because a lot of them do want to brush it off and go, you have Parkinson's, call the specialist, many times, and sometimes it's not warranted. That being said, though, yeah, give me a call because I'll try and deal with whatever it is and do my best to deal with your anxiety, to deal with the sleep issues. Like I said, if it's something that I'm not feeling I should do under my scope, then I have the fellows that certainly do some phone calls as well, or we end up talking to you as well.
Yes. So, I mean, it's, I will defend my colleagues because there are lots of excellent family physicians out there who are also overwhelmed and overburdened by, clinical care. As you say, our waiting list is 18 months, not because we're sitting around, that's because we have 4,200 outpatient visits last year in just my clinic. That's the volume. The second is the complexity of the neurological syndrome in general, whether it's Parkinson's disease or whether it's stroke is much easier because it's an event. It happens, and then after that there's an algorithm. The problem with Parkinson's disease, unlike much of other neurology, is that there is no algorithm. And so, 5 minutes? Yeah. So because there is no algorithm, it's important for us to be able to balance many of these things, and physicians outside are very uncomfortable with the complexity of the disease, whether the antidepressant will interact with the dopamine agonist, whether the antipsychotic or hallucination treatment will interact with the levodopa, and not knowing those things makes it, you don't want the doctor to be uncomfortable in doing that. So they refer those questions to us. We try to, hit back. And Heather is right. I mean, anxiety treatment could easily be managed outside. Constipation should be easily managed outside. It shouldn't land on our desk. But it happens all the time. So I wouldn't say feel free to call with anything, but if you're not getting answers, then I think call her. There's one thing I do want to correct. I know we only have 5 minutes about deep brain stimulation. I think you heard before the talk that there is no age limit for deep brain stimulation. That's incorrect, right? And so that information is wrong. And the reason it's wrong is because, not from the neuropsychological perspective, because Alfonso Fasano and I are very close friends, and Alfonso, director of the Movement Disorder Center for DBS, and I do that here. And the reason it's wrong is not because of the fact that, so there is an age limit. For STN DBS, rarely ever will we do anyone over 71. And the same thing is true at Toronto Western because I have their data. And,
I disagree.
well, I'll show you Alfonso's text to me.
I go to every surgical meeting.
Well, you want to see Alfonso's text to me? Have a talk to him. Have a talk. Because I'll show you on the screen his text. Because this was raised at the Copenhagen meeting about 8 weeks ago in Copenhagen at the MDS. And GPI is 75. And there's a reason, my dear. The reason for that is that the stereotactic localization, and I've done this 33 years, so I can tell you, a lot longer than even Alfonso has. So the ability to target STN, okay, is extremely difficult. And what we use to target is a Schultenbrand atlas. And that Schultenbrand atlas is a collection of many brains that are not Parkinsonian. These are not Parkinson's brains. So because of that, there's an average localization. So when we put the fiducial CT markers on the head and get a CAT scan and warp that, software that was actually developed in London, by the way, that is used to warp that CT scan onto the MR scan of the patient, and then the atlas, like a GPS, is used to give you your stereotactic coordinates. There's an error rate. That error rate is high. The older you get, the more the error. So you may neuropsychologically be cognitively well. I hope to be at 90 still playing chess. But at the same time, my brain is not the same volume as it was, hopefully, today, right? And so the idea behind it is that targeting and localization becomes really a problem, right? You're going down 6.5 inches into the brain. So neuropsych is one variable, but the ability to get into the right spot is another. And that's a critical. We have revisions that are required as it is because the localization is not accurate once that's the biggest reason. If you're demented, we're not going to do it anyway if you're 65, right? So it doesn't matter. So be careful when you're 80 trying to get that target. You're not going to hit it. It's just not going to happen, right? And so then this is the surgical procedure is serious. You're trying to localize something that is literally 9 millimeters cube, if you're lucky, right? In 6 inches down, right? In somebody's brain that is atrophied, right? So cognition is not an issue. It's the localization of the target. And even with, we used to do pallidotomies and thalamotomies years and years ago. That was the problem, that would make a lesion that would not actually meet the structural requirements of that. If we had a way in which now 3 and 70 MRIs, where we actually could see while we were doing, that's why the non-electrophysiology implants, so when we don't do recordings, there in the US, you can actually see the target, but even then, the hit rate is low. And this is the reason why, you can disagree with me, it doesn't matter really, but at the same time, this is the reason why. And I say we've done this for 33 years. And the first DBS was done in Toronto when I was a fellow with Tony and Andres. So, I've done this a long time. And we do electrophysiological guidance for that reason, is because we actually do recordings of the brain cells when we're inserting these electrodes. Even then, we have revisions, right? And go ahead.
No, I was just at the very end, because I know we're short in time, but we didn't get to the advanced stages. And so I just kind of wanted to add in, if anyone starts to develop hallucinations quite abruptly in that, go get your urine tested first. It's generally going to be an infection. Go get that checked out. Then if we need to, if it is cognitive decline and things happening as the disease progresses, then we can consider starting a medication. But I do get a ton of calls all of a sudden, and it's frightening to the caregiver, behavioral changes, hallucinations, so definitely get that looked into. And we could talk a whole nother session of the advanced and the cognitive, the falls, geriatricians, that sort of thing, but we're running out of time here today, so maybe next time.
A very short fireside chat.